I think the single biggest development in rheumatoid in 10, 15 years is maybe two. It's the emphasis again on methotrexate, trying to keep the patient on methotrexate. All the international studies and meetings in the last 2 or 3 years have emphasized that. If there was one message from the British meeting this year, it was get them and keep them on methotrexate if possible. And it's also the other main successful aspect of the treatment is the use of biologics, and that's transformed the treatment really of rheumatoid. The biologics are expensive, they're being audited at the moment, there's a huge choice, it's a bit confusing as to what's happening and what's going to be available in the next 3 to 5 years. But the use of biologics has completely transformed the treatment of rheumatoid. It's one of the main reasons I think that you won't see the severe erosive changes in joints that we saw so classically, as again I mentioned in our final med days, shall we say, those classic patients that one might have seen in your membership exam, those pictures that we all remember. They're not going to be around as much as they were because of biologics and methotrexate in combination. So it's early aggressive methotrexate treatment, and if that doesn't control, then get the biologics in early. Biologics are not for everyone. They're excellent medications. They're not smarties. They increase the risk of infection and reactivation of TB. But all the registers are suggesting that they're extremely safe. They don't cause heart, lung, kidney, liver disease. They don't increase the risk of cancer. They're extremely safe and very well tolerated, be they the injections or the infusions. The original biologics were your infliximab infusion, your Enbrel injection, then you had your Humira injection, then you had your Simponi injection, and more recently you've got your abatacept, Roactemra injections, your rituximab infusion, and more recently you've got other medications that are used for multiple things like colitis, psoriatic arthritis, psoriasis, but the main ones that I are mentioned there. The biologics are very well tolerated. The patients are very happy to use them. They are very well trained in how to keep them and travel with them. The initial fears of biologics losing their efficacy out of a fridge and things like that, they seem to have evaporated. For example, now previously Enbrel had to be kept in the fridge, etc., etc. Now Enbrel is stable at temperatures of up to 25 degrees for up to a month out of a fridge. So that affords you a huge facility in traveling. Our rule of thumb is that if the patient thinks they're going to be in places where the temperature won't be above 25, they can carry it with them. They shouldn't put it into the hold in the plane, for example. They should carry it in their luggage and their hand luggage on the plane and carry it with them. Now, ideally keep it in the fridge when they get to their destination, but you still have a month to play with, which is fantastic. When it comes to vaccines and biologics, we would like to get everybody vaccinated as much as possible. That's your annual flu jab, ideally your Pneumovac every 5 years. Now ideally these things should be given prior to the patient starting, but what happens is when the patient presents aggressively and there's aggressive disease and there's active disease, I should say, the patient wants treatment now. They don't want to wait weeks for the vaccination to take its effect, etc. So we end up vaccinating people once they've been treated. And the result from the vaccinations is quite good. It's not the 100% you'd get if you weren't on steroids, methotrexate, biologics, etc. And it might require repeat vaccines. It might require doing the Pneumovac sooner. So there's ways of trying to improve the efficacy of vaccination when the people are taking these things. But generally, get your annual flu jab, your Pneumovac. Try to avoid, or you should avoid, please avoid places where you would otherwise be advised to take a live vaccine, for example. I would actively discourage my patients from visiting any place where they would require live vaccines, as is common in other areas of medicine. Surgery is very important, and surgery is getting better. Of course, the upper limb orthopedic colleagues have hugely developed skills over the last 10 or 15 years. We used to dread sending patients for shoulder procedures, but now it's extremely successful. We've moved on to elbows. Elbows are becoming very successful. There's talk of wrist surgery that was simply unthinkable 10 or 15 years ago. We still do the small joints in the hands, or at least my orthopedic colleagues still do the small joints in the hands. we don't use washouts as much as we did 10 or 15 years ago. That they don't seem to be particularly efficacious. Certainly an early orthopedic referral, I think, can be extremely useful. I think as orthopedics develops, the idea of having a second, e.g. knee replacement, becomes less of a dread, because the techniques will become better, the procedures will become better, safer, better effects, less infections, those kind of things. So the idea of, well, I better wait till I'm much older till I get my knee. No, I think it's wasted on the young, if you like. If you want to keep working, get your knee done, your hip done, whatever it is, your shoulder done, to allow you to keep working. And okay, so be it that you might need a repeat procedure in a couple of years' time. I think that the facility will be much better accepted in a couple of years.